Good morning. My name is Dr. Lisa Herlock, and this morning I'll be demonstrating the cardiovascular examination. As with all examinations, this starts at the introduction to the patient, followed by inspection and then palpation. Good morning, sir. Would you mind if I examine you?
Oh, that's fine.
Okay, all right. My name is Dr. Herlock. All right. Okay. So, in all patients, during all the examinations, you have the patient as comfortable as possible, flat in the bed. If in the cardiac patients, not all patients can lie comfortably flat. And in that case, you'll have the patient's head elevated. Okay. The patient should all be in the anatomical position with their palms facing upwards. And for the cardiac examination, we have their chest exposed, and we expose the patient up to at least their knees. Are you comfortable in this position?
Yes.
Okay. All right. In the cardiovascular examination, we start with inspection at the foot of the bed. We look at the general patient and looking at the patient's nutrition, looking at how well nourished the patient is, how comfortable the patient is, if they look pale, if there's any evidence of jaundice or cyanosis that we can see from the foot of the bed. Then we focus on the chest. We look at the symmetry of the chest walls. We look for evidence of an active precordium, which is pulsation at the apex of the heart. We look for evidence of any obvious distended veins in the chest. We look for evidence of respiratory distress, tracheal tugging, intercostal recessions, which we can see just from inspection. Right? We also look at the legs of the patient to see if there's any evidence of edema. But at this point in time, we do not touch the patient's legs. We then move to the hands of the patient. Looking at the hands, you're looking for any evidence of cyanosis of the fingertips, which can indicate peripheral cyanosis, or there may be cyanosis of the hands alone, hands totally, which can be a part of central cyanosis. Okay? You look for evidence of pallor and always evaluate both hands. Any evidence of icterus or jaundice, which can be sometimes seen in the hands. In evaluating the hands, we also look for, in the cardiac system, we look for any evidence of infective endocarditis, which can be seen as Janeway lesions, which are macules, non-tender macules on the palms of the hands, or Osler's nodes, which are tender nodules usually on the fingertips. These are not common, but we don't want to miss them when they actually are present. Again, we also look at the nails, because there may be evidence of hemorrhage in the nail bed in patients with infective endocarditis. In looking at the hands, we also look for evidence of clubbing, increased longitudinal curvature of the nails, evidence of sponginess of the nails, and also loss of angle. Between the fingernail and the finger fold. Patients with valvular lesions, such as infective endocarditis, patients with congenital cyanotic heart diseases, such as tetralogy of Fallot, may have clubbing of the fingers. We then move on to assess the pulse of the patient. The radial pulse is what is conventionally used, and we usually evaluate the radial pulses with the four lateral fingers. So when we're evaluating the radial pulse, we evaluate the rate, the rhythm, and the regularity of the pulse. We also evaluate for pulse volume, low volume, normal, or high volume pulse. We then evaluate for radial synchrony, again using the 4 fingers as opposed to the thumb, and assess to see whether there's synchrony between the 2 radial pulses. Okay. Then we also evaluate for radiofemoral delay, and this is done by palpating for the femoral artery. Expose you a little bit, sorry. And we palpate by palpating for the ASIS and the pubic symphysis, and halfway between is where the femoral artery is located. And we see if there is radial synchrony. This should not be done through the sheet or through the patient's pajamas. You should perform this maneuver by direct palpation. Okay. Okay. Another maneuver that we perform with the radial pulse is by palpating for the presence of a collapsing pulse. We feel for the radial pulse with the distal metacarpal joint. We palpate for the pulse and then release our hands until we just stop feeling the pulse. Then we say to the patient, I'm going to raise your arm. Don't help me. I'll do it on my own, okay? Then we raise the hand. And we feel if the pulse has started, if we're able to feel the pulse again. And then we put the arm down. And in a true collapsing pulse, the pulse would disappear. Therefore, if the patient has a collapsing pulse, on initiating the maneuver, we're unable to feel the pulse. When we raise the arm, the pulse will return. And then when we place the arm down, the pulse will disappear. And that's a classic collapsing pulse. Okay? And we get collapsing pulses in patients who have high volume pulses, and also in patients who have high runoff from the aorta, for example, aortic regurgitation. High volume status or hyperdynamic status, as in anemia, pregnancy, thyrotoxicosis. Those conditions will also create a collapsing pulse. Okay. The next maneuver that we do perform on the patient is the blood pressure. But at this point in time, I will not be doing the blood pressure because that is ideally done with the patient sitting up. We can demonstrate this thereafter. All right. Okay, the next evaluation is evaluating for pallor in the mucous membrane. Evaluating for jaundice. Can you look down for me, please? Look at my hands. Looking for jaundice of the sclera. Can you open your mouth for me? Lift up the tongue, looking for any evidence of central cyanosis, which is noted beneath the tongue. In the cardiovascular examination, we also evaluate for evidence of caries of the teeth, because that can put the patient at risk for infective endocarditis. Okay. Classically, in the cardiovascular examination, we do not evaluate for lymph nodes. I can stop now. I'm going to sit up. In the evaluation of the jugular venous pulse or the jugular venous pressure, the patient should ideally be elevated at about 45 degrees angle. Okay? The patient should have their head slightly turned to the left side. And then the JVP, the jugular vein, is located between the 2 heads of the sternocleidomastoid up to the earlobe. So you'd be looking for a pulsation between the 2 heads going all the way up. All right? There are some features that suggest that the patient has a jugular venous pulsation visible. And these features include the fact that there is a double pulsation as opposed to a carotid pulsation, which would be a single outward pulsation. Also, the jugular venous pulse would be affected by certain maneuvers that we can perform. This includes having the patient take a deep breath in, and with that, if the JVP is elevated, there would be a fall in the JVP, right? Also, we can have the patient change position. With the patient sitting upwards, if the JVP is elevated, again because of gravity, the JVP will also decline. Okay? And one of the maneuvers which we often use is the hepatojugular reflex. And with that, in fact, you can palpate any part of the abdomen. But once you increase the abdominal pressure, if there's an elevated jugular venous pulse, then the pulsation will become more elevated and more prominent. Before performing this maneuver, you have to ensure that the patient is not having any pain in the abdomen. So you ask about pain prior to pressing on the patient's abdomen. If the JVP is elevated, we actually want to measure the height of the JVP. And with this, we use a ruler from the height of the JVP across to the angle of Louis, and use another ruler to drop a perpendicular line to the angle of Louis. And that would give the elevation above the angle of Louis of the JVP, jugular venous pressure. And we normally add about 3 to 5 centimeters to that to give the elevation of the JVP in terms of centimeters of water. Okay? So we find the height of the JVP, a straight line across, and a perpendicular down to the angle of Louis would be the height of the JVP, adding 3 to 5 centimeters to give the actual JVP measurement. Okay, now we're going to palpate the patient's chest. The initial palpation begins with the trachea. You check for centrality of the trachea by placing your second and fourth finger on the medial edge of the stern of the clavicle and palpating with your middle finger the trachea extending into the sternal notch. And you see if there is equality in the distance between the trachea and the right and left side. And if this is so, then the trachea is central. Okay? This is might be slightly painful for the patient, so you should just ensure that you don't palpate too deep or too deep for the patient's comfort. Okay? The next thing we do is palpate for the apex of the heart. Now, some patients may have the apex of the heart on the right side of the chest, and so we often start with a palpation. Have you got anything? Okay. Yeah, I'm going to do it before I.
Probably should have told him, like, how do you measure?
Oh yes, you have to go back and do that. Yeah. Yeah. Between the Okay. All right. So in evaluating for the apex of the heart, again, some patients may have the apex of the heart on the right side of the chest, and so you should begin palpation with both hands until you feel the apex of the heart, and then you can try to localize it with a fingertip. Okay. The apex of the heart is the most lateral and inferior point at which you can feel the pulsation, or the pulsation can lift your fingertip. Okay? So once you've located the apex, you try to localize it now by palpating for the angle of Louis, which is where the second rib is located. The space below this is the second space. Then you palpate third, fourth, fifth space, right? And then with that now, you can decide whether the apex beat is located in the mid-clavicular line versus the anterior axillary line versus the mid-axillary line in patients with an enlarged heart. Most normal patients will have the apex of the heart located in about the 5th left intercostal space in the midclavicular line. Once we've palpated the apex, you decide on the character of the apex. Is it thrusting? Is it heaving? Is it difficult to localize? Is it a diffuse apex beat? In some patients, we are unable to palpate for the apex beat, and there are many causes of this. Obesity, a thick chest wall, patients with obstructive lung disease, we may not be able to palpate the apex at all. In some patients, when we have difficulty palpating, we may have the patient turn on their left side and try again to palpate the apex and then turn back on the right side. While at the apex of the heart, we are also feeling for any other abnormal features, such as thrills. We palpate for thrills at the apex. Then we move to the left sternal edge, again palpating for thrills. The upper left sternal edge and the right sternal edge. Okay. While palpating along the left sternal edge, we're also feeling, once you palpate and you feel a thrill, then you have to evaluate the timing of the thrill. Is this a systolic thrill or is this a diastolic thrill? How do we evaluate this? Well, first of all, we evaluate by the palpation of the carotid artery. But even before we palpate the carotid artery, you should just have a quick listen over the carotid artery to ensure that there are no obvious bruit to suggest carotid artery stenosis. Okay, no obvious bruise here, so I can quickly palpate the carotid artery. And if I feel a thrill that comes with the carotid pulsation, that is more likely a systolic thrill, while if it comes after, then it's more likely a diastolic thrill. And that is how I would characterize the timing of the thrill. So I would do this at the apex of the heart, at the left sternal edge, and along the upper part of the sternal edge. Okay? Along the left sternal edge, I also palpate for a palpable P2. Again, how would we decide the timing of the P2? Again, it would come after the carotid pulsation. And we'd feel if there's an obvious palpable P2, which is usually heard along the upper left sternal edge. It's normally felt along the upper left sternal edge. We also evaluate for left parasternal heave, in which we place the lateral border of the hand along the left sternal edge and see if there are any obvious heaves of the chest, which may indicate left atrial enlargement or right ventricular hypertrophy. So we have to take a patient to hold your breath for a few minutes. And then we see if the fingers are moving, obviously, with a heave. Breathe normally now. No obvious heaves in this patient. In auscultating with the stethoscope, we auscultate with both the diaphragm of the stethoscope and the bell of the stethoscope. And we can interchange with these parts of the stethoscope by just turning the tubing of the stethoscope. Typically, the diaphragm allows us to listen for high-pitched sounds. These include heart sounds 1 and 2, and the majority of the murmurs that are heard in the heart. The bell allows us to listen for low-pitched sounds, and these include S3 and S4, and the murmur of mitral stenosis. Now, while auscultating the patient, we have to use maneuvers to accentuate the heart sounds as well as accentuate any abnormal sounds that are heard. And so during my demonstration, I will add the maneuvers to enhance the sounds of the heart. For example, if the murmur of mitral regurgitation is heard, then we have the patient take a deep breath in and out, and mitral regurgitation, being a left-sided murmur, will increase with expiration and gets softer with inspiration. Similarly, tricuspid regurgitation is increased because it's a right-sided murmur with inspiration and decreases with expiration. And so that is an important maneuver that should be performed when auscultating for all the murmurs. Now, when we initially listen with the diaphragm of the stethoscope, we listen initially for the heart sounds 1 and 2. When we auscultate heart sounds 1 and 2, we can determine whether it's S1 versus S2 by, again, palpating with the carotid artery. So S1 will coincide with the first heart sound. And so we are able to evaluate S1 versus S2 and subsequently the timing of any additional sounds. Okay, turn on your left side for me, please. Take a deep breath in and blow out. Okay, thank you. Turn flat on your back. Take some deep breaths in and out for me, please. As you noticed, when I was at the apex, I used my bell. I listened for the S3 or S4 or the mitral stenotic murmur, and then I turn the patient on the left side, which accentuates the mitral stenosis murmur, and had the patient take a deep breath in and out to see again if the murmur is accentuated in expiration. All right. Then I listened in all the other areas with the diaphragm, listening again for heart sounds 1 and 2, how loud these sounds are, how soft they are, if there are any additional sounds between S1 and S2 suggestive of a murmur, and again with the patient taking deep breaths in and out to accentuate the sounds of the murmur. The other maneuver that we often use is having the patient sit up to listen to the sound of aortic regurgitation. In evaluating for aortic regurgitation, we have the patient seated and we listen in the secondary aortic area with the diaphragm. We listen for the murmur of aortic regurgitation, and we have the patient take a deep breath in and out, blow out, and hold it in the breath in expiration, and we listen to see if the sound is accentuated. Take a deep breath in for me, and blow out, and hold it. Breathe normally for me. Okay. Okay. All right. You can lie down. Okay. All right. In further evaluation of the cardiovascular system, we also evaluate for the presence of hepatomegaly. Is there any tenderness in the abdomen? No. Okay. And then just palpate over the liver to see if there's any tenderness in this area. And I quickly percuss to see if there's any hepatomegaly for the lower limit and then for the upper limit. Okay. If there is hepatomegaly, we also assess for a pulsatile liver, which can occur in patients who have significant tricuspid regurgitation. We place one hand beneath the position of the enlarged liver, and we lightly press with the upper hand. And if there is hepatic pulsation, the hand would be seen pulsating. Okay. Can you sit up for me? So with the patient sitting up, we evaluate for crackles in the lungs, signs of left ventricular failure. So we listen to the bases of both lungs. Take a deep breath for me and blow out. Again and out. While the patient is seated, we also assess for sacral edema, which can be seen in some patients who, after being in bed for a long time, they may not have peripheral edema, but there will be edema at the level of the sacrum. You press on the sacrum and see if there's any pitting edema, and there's none here. Okay. Then we go to the foot of the bed, and we again look at the toes for any evidence of cyanosis, any evidence of clubbing of the toes. And we feel for the peripheral pulses. We usually feel for the dorsalis pedis bilaterally. Right. And we also evaluate for any evidence of edema by pressing on the foot. And then if there is edema, we evaluate the extent of edema up the legs, okay, by gentle pressure, of course, without causing pain with the patient. In evaluating the legs, we also look for any evidence of peripheral arterial disease, any hyperpigmentation, any evidence of ulcers of the legs, which can also indicate that there is venous or arterial insufficiency. Okay. And with these maneuvers, auscultation, palpation, we're able to give an assessment of abnormalities in the cardiovascular system.